Morning, everyone. Welcome to today's presentation, How EMDR Helps Adults and Youth in Recovery from Addiction and Trauma. This webinar is part of a series hosted by St. Clair County Community Mental Health during the month of September, which is National Recovery Month. Today's session is being recorded and will be uploaded to the CMH YouTube channel for future reference. Please feel free to use the chat box to ask questions and add comments you have at any time during this webinar. And if time allows at the end, we will answer as many questions as we can. Our presenter today is Shannon McKeever. Shannon works here at St. Clair County Community Mental Health and at Blue Water Counseling. She has worked in the field of clinical social work for 12 years. During her undergraduate work, she received a certificate in addiction studies from Madonna University. She then went on to get her master's degree in social work from Michigan State University. She's a fully licensed MSW and a certified advanced alcohol and drug counselor. She is trained in many evidence-based treatments, including eye movement, desensitization, and reprocessing, or EMDR, which is what we're talking about today. So with that, I'll turn it over to you, Shannon.
Thanks, Sarah. So, hello. As Sarah said, my name is Shannon McKeever, and I am going to be your presenter today. We're going to start with a couple polls just so I can kind of have an idea of where we are starting at. I know that we had talked a little bit about, so I have an idea of where we're at. So Karen, is it possible to bring up those polls first? Thank you. So I just kind of want to know, how much do you know about EMDR? Kind of trying to figure out where my audience is and just kind of understand what your knowledge base is. And we'll just leave it up for a couple more seconds just to hopefully, because this is just kind of like gauge to see. All right, so it looks like the majority of you know some, at least you know that it exists, but it sounds like you don't have a huge idea. There's some people that actually use it, some people with a good idea. We have somebody that actually has had EMDR, and then there's a portion of you that don't know anything at all. All right, thank you for sharing that. And I have just one more, just to kind of see what brings you here today. Looks like somebody took their first EMDR over the weekend. Of somebody else. So we've got some people who are just kind of starting that journey in using it in their practice. Some people that have done it themselves. Okay. So got some people free CEUs. I mean, those are a very rare treasure. I have some people that are interested in finding out about EMDR, want to learn how it can be used for treating addictions. Some people are just curious, and you know, there's always that other piece to it. So thank you so much for sharing what brings you here today. So starting off with, I am going to have a PowerPoint. Just give me a moment. There we go. So let's start with talking about what is trauma, right? So we need to know what trauma is in order to be able to look at it through the eyes of EMDR. So I was watching a video on Bessel van der Kolk, who is one of the leading experts in the field of trauma. And he said something that I really appreciated, so I wanted to share that on here. And trauma is not the event that happened, but the trauma is how you respond to it. Some people will experience similar events and not necessarily have that same response. Some people can witness or be a part of things that others would perceive as trauma, but they themselves don't internalize it like that. When we have support systems in place, when we're able to talk about it, when we're able to process it at the time of trauma, that helps reduce the internal response that you end up with if that's not done. So it's subjective to the person. So later on, we'll talk about subjective units of distress or subjective units of disturbance that's used in EMDR. And that's the reason why we use that, because I can assume how I would respond to something, and that still would be a guess. But I have absolutely no idea how somebody else will. It's based on their life experiences. It's based on so many different temperament. I mean, so many different variables for that. So the other thing is, there's a perspective of what trauma is versus reality. Society thinks a lot of the time, in my experience, being in session and talking to somebody prepping for EMDR, people will say, well, I haven't been through trauma. I just, lost a parent and watched them pass from a severe illness. And, this is a parent that they were close to, and those types of experiences. And I, looking at it going, okay, but this is something that you still react to the world around you due to that. So in criterion A of PTSD, that might not meet that qualification, but it's still a trauma to the person. It's still something that they're reacting to today from something that happened years ago. So kind of looking at, okay, there's this definition of trauma. There's society's perspective of trauma, which is something that you would see on the 11 o'clock news, or it's something that you might have, you might look at as, somebody going to war, which that also is trauma, but it doesn't negate because somebody had something, quote unquote, more significant. That doesn't negate your experiences or our individuals' experiences. So, storage of trauma in the brain, I kind of want to touch on this. So when we have a trauma, what happens is our fight or flight system opens, right? We become aroused. We kind of go into that survival mode. So fight or flight systems in our brain open up. We react as how we need to react to be able to survive, whatever that looks like. I mean, we talk about fight, flight, freeze, or fawn. These are all different options for responses for people. So you react however that is. And then when the trauma stops or ends, we de-escalate, right? So our limbic system or our trauma part of our brain, it starts to close up because we don't need it anymore, right? But one of the challenges with trauma is also it can store the feelings, pictures, emotions that we had, these experiences, these triggers, these things that we saw and the things that we did in our brain, as in that section of our brain. We're created so our limbic system and our frontal lobe don't talk. And there's for a reason, because if we don't have that type of interaction in our brain, we would be sitting in fight or flight all the time, right? So it's only accessed when needed. Our frontal lobe is where we kind of talk, right? This cognitive part of the brain. That's what I'm using right now. I'm not in fight or flight, or maybe I am, but just a little bit of nerves. But we're typically not running in that system. So what happens is we have the trauma, we have the system in our brain open, and then when it ends, it closes. If it is not processed, as we talk about it, that system can open back up because we still become aroused when we're talking about, oh my gosh, what happened to me? This is what. So within that system opens up, you're able to process the thought, it closes down, it opens up, process the thought, closes down. But if we avoid that does not happen within our system. So then what happens is it suppresses into our brain and we don't necessarily talk about it. Not that we can't remember it, but we don't talk about it. So therefore triggers that remind us about the event will kind of trigger our nervous system to pop back open because we think that we're in danger again, because we never processed the isolated incident or multiple incidents in which we had. So multiple environmental factors kind of play a role in trauma too. There's people that have had experiences that become their normal, quote unquote normal, that necessarily other people didn't have. So if per se, you're a hunter, you're an avid hunter, that's something that you did all the time growing up. To see an animal pass away, that would not be as stressful an event as somebody who is maybe part of an organization that is very, very supportive of animals. And so if they witness that, that might store in a system, that might be a different type of trauma for them. So there's multiple forms of treatment. I do want to kind of give a nod to, there's CPT, there's IFS, there's PE, there's different forms of treatment for trauma, but today EMDR is going to be the focus. So kind of a little tidbit about the history of eye movement desensitization and reprocessing, or EMDR. It was developed and studied and published by Dr. Francine Shapiro in the late 80s. I don't know, some of you, the late 80s might be a long time ago. For me, late 80s was yesterday. So that different, so to me, it's a newer and type of therapy. And so that's kind of why we're just kind of getting the ground under our feet for it. Like, people are still learning about it. The research is constantly happening about it. There's still things, new types of protocols that are coming out on a regular basis, because it was only developed in the late 80s. In 1990, the EMDR Institute was founded according to their website. And the EMDR Institute is a place where you can find trainings. You can be able to find therapists that are registered within that have taken the trainings there, find out information. Then in 1995, EMDRIA, which is the Eye Movement Desensitization and Reprocessing International Association, was founded. EMDRIA is now, it represents an international movement for EMDR. So I was just at the EMDR conference, the EMDRIA conference, over the weekend, Saturday and Sunday, and then this coming Saturday and Sunday, I'll also be doing a virtual. And when we go into the to the training, like, we have this chat, and in the chat we introduce ourselves, Shannon from Michigan. And we had people from Japan, we had people from Germany, we had people like from all over the world, including all over the United States. So a couple people were in Hawaii, Alaska, and then, the 48 here. So it was just really interesting to see how really widespread that was when I was able to see all of these people coming from different places. One of the trainers was actually from the UK. So it was, again, kind of talked about how it's become an internationally respected treatment for trauma. When we do EMDR, what it is it assists people to reprocess trauma using bilateral stimulation, okay? So these are the tools that I use. These are actually my personal tools that I have here on the bottom. One of them are TheraTappers. It's not a promotion, it's just information that I use at both settings. I have those at both settings, because what those are is they vibrate side to side to bilaterally stimulate your brain. But even though it's called eye movement desensitization and reprocessing, they found that bilateral stimulation, stimulating the left side of your brain, which then, the left side which creates right side of your brain to be stimulated. That's the emotions, that's the pictures of the memory. Stimulating the right side, then stimulates the left side of the brain. That's the facts. That's that analytic piece of what happened. So when you have that all opened up, you're able to see the emotions, the pictures, the experience in its whole, going back to remember the memory. One thing that I always find interesting when I'm working with somebody with EMDR on how many times they say, I didn't even remember the dog was there, or I didn't even remember that part of the conversation. Because when opening up the system, it gives these extra pieces at times for you to be able to experience, again, that whole picture, to be able to understand what happened with today's perspective. I often talk to people about don't judge yourself today from yesterday. Don't judge yourself from yesterday with today's perspective, right? Today's information is different. It's hindsight. It's things that we had experienced. And now we have all of this other information, the coulda, shoulda, wouldas, input from other people, the way that life has went since then, 2 years later, 3 years later. So we have all of this, and we look back at some of our experiences, in our teens, 20s, childhood, and we say, why didn't I? If I just. And that's judging ourselves because we have different information now. We have a different thought process. We're in a different era. I mean, when you look at different generations, people will say, we're in 2022. If we're talking about 1956, that looks different. Life was different then. So saying, this happened in 1956, this is how somebody, a loved one or a caretaker handled it. It's so different. It's such a different place. So that's another reason why not looking back and judging with today's information is beneficial. But when we do open that up using EMDR, we're able to look at it as a whole, today's information, yesterday's experience, and be able to look at it like, oh, okay. EMDR is an 8-phase approach. So phase 1 is just kind of like assessing readiness, doing assessments, kind of understanding what's going on. Phase 2, and forgive me, I forgot my sheet, so I'm just kind of going by memory. Phase 2 is our resourcing piece, kind of getting things together to be able to move forward, doing history taking, getting a trauma timeline together. This is kind of like what experiences are still affecting you today that have happened. A bonus in EMDR is I need to know as much or as little as the individual is willing to share. Not that I don't want them to access and discuss that, because, that's part of that disclosure, to be able to really fully process it. And the more information I have, the more I'm able to assist with cognitive interweaves, let's say, which are when somebody's processing. Usually it's used Socratic questioning. So if you could talk to yourself today with today's brain, what would you say to yourself when you think that? Or if you were talking to a friend, what would you tell them? To add an extra question so they can process, because sometimes people are so have such a strong belief system, they get stuck in that belief system. So phase 2 is kind of getting that history information, getting those resources together. We use resources called Safe Space, which is creating a place in your brain that is an adult space that you can become, that you can, that just kind of de-escalates you and that you enjoy to be in. I've seen a multitude of different experiences, but every one of them, when we set up Safe Space, asked to go back in. And usually, I'll just say, go back in one more time and let's just sit there, make sure that it's set up for you. That's using bilateral stimulation is what helps you create that. So it's called RDI, resource development and installation. So we develop the resource and then we do an installation. So like the tappers would go back and forth, or the middle thing is my light bar that, and I'll go back to what that does, but using the light bar or the other form of tappers, those will allow you to be able to kind of, again, open up those spaces in your mind to kind of really solidify that place in your mind. And this is usually the beginning of learning about these tools that we have, the tapper, the eye bar. The eye bar has the one I have has different colors. It can go end to end, or it can scan back and forth. Some therapists use their fingers and just go back and forth and ask you to follow the fingers. I bought things so I don't have to, wear my arm out doing that, but it's, and then the other one, the other piece, the other tappers, not the ones with the green handles, but the ones with, I guess that would be gray or cream colored handles. Those ones actually coordinate with the light bar. So they have a little R and an L, you put it in the right hand, the left hand, and then they vibrate according to where the eye movement is. So going back and forth and having, so that's using bilateral stimulation in two different forms. Another form is sound, a sound going back and forth that can also create bilateral stimulation. So going back to the 8-phase approach, phase 3 is kind of like the setup for the memory. So what we do is we say, what picture best represents the memory? What is the thought of yourself in this that you believe about yourself due to this memory? And then we go through other different steps. We look at the SUDS. We look at the VOC, the validity of cognition, which I'm going to go through terminology in a second here. So we go through and get it set up. And in phase 4 is when we actually start reprocessing. So that's kind of when things start to go in motion. Phase 5 and phase 6 for some reason are eluding me. I remember phase 8 is like kind of checking back in. So the end of the session, the next session, we check back in. Where are your SUDS at? Did they decrease? Did it increase? Do we have to process more in this? So we always look back at that memory so we can ensure that we move forward and that that somebody's not stuck in that piece. Some terminology: bilateral stimulation, when something stimulates both sides of your brain, right? So it's vibration, it's sound, it's visually. We can do that with ourselves if we don't have the equipment. People tapping their feet side to side, tapping their legs side to side. They talk about a butterfly tapping side to side. Those are things that you can do on your own, or you can also use, in therapy, we use these equipment pieces to be able to help. Body scan. Body scan is part of phase 3, and also when you get into phase 5, that's kind of scanning from your head down to your feet to see if there's any disturbance. There's a book by Bessel van der Kolk that is called The Body Keeps the Score. And it talks about how trauma gets stored in our body. So that's how come at times, you'll have a thought about something and your stomach will turn, or your chest gets heavy, or your throat, or you feel like you can't speak, or a headache, or shoulders, or these are all body sensations that people will experience. Sometimes I've had people experience a body sensation that actually represents what happens to them in an area that it happened to them. And sometimes it's just, you have a headache, or you feel like you're can't speak, or that your throat has a lump in it, and it doesn't necessarily fully represent the trauma, but there's some type of connection there. So and sometimes when we're processing, if somebody can't come up with a memory or they get stuck, sometimes we do a body scan and we just sit with that somatic, that body sensation. We just sit with that and notice that. And I've had experience when people would come up with then what it is, because, okay, let's just notice your chest and let's just kind of go with that. And we move forward in the processing, and then they're like, oh, I remember my brother was sitting on my chest. Okay, that's where that came from. Negative cognition, that's what do you believe about yourself when you think of that target memory or the original memory that you start with for reprocessing. So negative cognitions are anything from the world's not a safe space, or I'm not safe, I'm not a good person, I'm a liar, I'm not enough, I'm never good enough. Those things that our inner critic kind of yells loudly to us when we think of those memories, that's kind of that's what we look at as our negative cognition, that self-talk. When we think back, it's my fault. Those are things that, we may experience. And again, when the limbic system opens, we gather the information. That's what gets stuck with that picture, right? That's what gets stuck in there is the piece of that negative talk, that thought process with the pictures and the experiences, the information that we had during the trauma. So that's a lot of the time where, like, I know I'm confident, but I don't feel it. Or I know that I'm a good person, but I don't feel it. Like that disconnection, a lot of the time it's because there's somewhere in you that something happened that creates that connection in your mind that just doesn't allow your frontal lobe or that higher reasoning, the things that we've learned, to connect with it. So that's how we can feel and think differently. I know I'm safe, but I had a trigger and I'm having flashback, and so I don't feel safe. That's that difference. So going back to RDI, I already kind of explained that, creating resources for people to assist them with EMDR. If we are unable to complete the reprocessing, that's where part of those resources come in. We will do the safe space, and then a container is the other one, a place that you can lock up the information so you don't have to deal with it at that moment. It's not for avoidance. It's not to avoid thinking of the memory. It's about not living with the distress of the memory from this week to next. So we're going to open that back up. We're going to pull that out. We're going to look at it again. I just want to make sure that from this to next, we can minimize some of that experience. A set is 24 or more bilateral stimulation. So 1, 2, that's 1. Back, forth, that's 2. And we do that a minimum of 24 times through each set. And then what we do is we stop, we check in. What do you notice? What came up? Like kind of getting this brief information in the reprocessing to then be able to move forward, or then again to add that cognitive interweave. So I'm never going to be able to be okay. Okay, well, if that were to happen to your friend, what would you say to them? Just kind of think about that and go with that. And go with that is like the term beyond terms for EMDR. Just kind of like take that thought and continue moving forward. Subjective units of distress, the person's perception of the distress that they are experiencing when accessing the memory. So we go back to accessing the memory. So we're going to go through a set. We're going to go through until it either starts distracting, till we get to the end of that thought process, whatever it is. And then we're going to go back to target, which is that target memory, going back to that original space, the original memory that we identified. We're going to go back to target, and we're going to talk about, what that is and where that goes to see if there's any other path that's cleared, because I might clear this part of it, the thought, or going through the memory and getting the information again, but I might not be done. So you want to go back to the target memory to then move forward again. There's a TISIS worksheet that can go with that. It's for between sessions. So you identify the triggers, what you imagined, what thought came up with that. You're kind of looking for those negative cognitions, the emotions that you're feeling, and the sensations in the body, and then you put a SUDS to it. Then you talk about an intervention, going to safe space, or looking at other types of skills that you can use, and then what SUDS you have after that. The VOC, when we look at what do you believe about yourself, what's that negative belief, we also look at what is a positive, what do you want to change that to? So it's my fault could change to it's not my fault, I didn't do anything wrong. So then when we start, we say, okay, how valid does that feel on a scale of 1, not valid at all, to 7, completely true? Where are you at? And usually, well, always, your SUDS, your 0 to 10 scale lines up with your VOC, or the validity of the cognition. Wow, malfunction. So those kind of line up. So if things aren't true, your SUDS are going to be higher. So 0 to 10, 0, no disturbance at all, 10 as much disturbance as you can experience. So if you're at a 9, your VOC is probably at a 2 or a 1, because it's not true, because I'm distressed and I have this belief about myself that does not match with it's not my fault, I did nothing wrong. So this is just kind of some of the terminology. The professionals and benefits to EMDR. EMDR can be provided by a mental health professional that has been trained in EMDR. There are 2 phases to the training. There's part 1, part 2. Part 1, I took an intensive. So I did part 1 and part 2 in a 5-day session. So it's my understanding that when you do them separately, you go part 1, you can go out and use it, then you come back and you learn part 2. But again, like the way that I learned it is I did everything in 5 days and then I was off and running. There's 3 different levels of training. Once you're trained in EMDR, you can use it. Then after that, you can move on to certification. Certification is I don't know if you see this thing or not. Certification is after you have processed with 75 people, and you do, I want to say it's either 10 or 20 EMDR specific credits to EMDR, and also do 10 hours of individual consultation and 10 hours of group consultation, you can become certified. That's what I'm currently working on. I'm in that process. I have the education piece done. I have the individuals piece done. I'm just finishing up my my consultation. After that, it's a consultant, and the consultants are the ones that can provide the consultation for others. That is 100 and something individuals doing doing the process with. And then there's some other protocol, but obviously I haven't made it that far. But there's, I want to say it's 150 people. I want to say it was doubled. And then you have other things, you have another set of trainings that you need to do. And then you need to be able to do more consultation hours, both individually and in group. And then you can become a consultant in training. And then you have to have a consultant supervising your consultation for others. And then you'll be able to move forward. So these are just multiple diagnoses and symptoms that can be benefited from EMDR: panic attacks, chronic illness, depression, bipolar, dissociative disorders, and as you see also here, substance use and addiction. So we're about to step into substance use and addiction. So are there any questions up to this point that we'd like to touch on before I move on to how it benefits substance use disorders? So yes, all right, I'm looking here.
All right, Shannon, I just want to make sure you could see there's a one in the chat kind of right at the bottom there from a slide or two back. I don't know if you want to respond to Christine.
Yeah, so there's a couple of them in here. So is EMDR considered an evidence-based practice? Yes, it is. It's an evidence-based treatment. There's a lot of research behind it. You can actually find it also on the PTSD VA site. And it is one of the encouraged treatments for people that have had PTSD that the VA also supports. Are you saying that you move your fingers back and forth a total of 12 times for each EMDR use? Now you go 1, 2, 3, 4. So it goes 24 times. So a set is, you can't really see my hand, so let me do this. So a set is out and back. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, up to 24 times, well, 24 times or more. I usually average between 28 and 30. I also like to jot notes on things so I can go back to them. So sometimes it ends up like 35 because one of my, the TheraTappers don't have a counter on them. So I can kind of get lost in that. Thank you for the 12 credits. It's 12 credits, I guess, for Andrea. Can you be trained and not certified? Yes, you can be trained. As soon as you're trained, you can use EMDR. Some people just stop there, and that's okay. That's, you know, I just want to kind of move forward because this is a form of treatment that I feel extremely passionate about and something that I really, I'm really enjoying doing. And I have seen progress in both substance use and specific and trauma, and I just and other types of addictions. And so I am just very passionate about it. That's the reason why I'm moving forward. All right. If there are any other questions, please don't hesitate to put them in the chat. I'm trying to keep an eye on time so I can make sure that I address those. So there are different types, 4 different types of EMDR and substance use training. This kind of explains. I actually was trained in DTOR, which is desensitization, and urge reprocessing. So this is specifically focusing on urges to use and triggers that people experience. It's a protocol. The one thing I like about this protocol is it can be used in and of itself and create reduction in triggers and urges. Somebody does not have to be sober or living a life of abstinence to use that. They just have to abstain and not be under the influence while doing that. So you can't use, you know, we're going to look at an earlier appointment. You can't use that morning, and you need to not use until after you leave. So like you need to be sober and abstinent while we do this piece. But if somebody is still like in the pre-contemplation stage or contemplation stage, probably the contemplation stage or preparation stage of use, we can still do this. You don't have to be action or in remission. So that's that benefit to this. That's part of what drew me to it. CraveX, it's a craving extinguishing approach. The approach hinges on reprocessing the addictive memory, which results in the cravings to be reduced. But these other 3 from when I was doing DTOR, those other 3, you do have to have somebody that's either in action stage, so actively not using, or in maintenance stage of not using, to be able to use those. So for the individuals that I provide services for, I just thought it was a benefit that, you know, to do the DTOR approach. So I'm going to kind of focus on that for the remainder of the session or the training. So I have two different trainings. Two different videos, which are slowly loading. I don't think I'm going to do this one on unless we have time. AJ Popke is the one who created Detour. He actually was from the birth of EMDR. He knew Francine Shapiro. He then created this to become he wanted to create a protocol for EMDR to stop smoking, and found that he had somebody that he did the stop smoking, and they actually continued smoking cigarettes but stopped smoking heroin. So which they had not disclosed to him. So they had stopped smoking. It just wasn't necessarily what his perception was going to be, and it wasn't all the information he had. But with the protocol, that's what he found, and he kind of moved forward with that. Resources for this are internal states. You're going to see this in the video. Uses is the level of urge. So instead of using the subjective units of distress, you're going to use a level of urge to use, right? So or to do the action. So that's what we're going to focus on. The SUDs we don't focus on. One of the benefits is if something comes up though in doing the Detour protocol, we can move right into EMDR and reprocess that memory. We can just kind of keep moving forward. So then we'll start talking about SUDs. Instead of targeting the trauma, it targets the urges and triggers. So I'm just gonna, this is a YouTube video that I had found, and it kind of shows the beginning setup of a Detour protocol, and I wanna share it with you so you can kind of have an idea of what it is.
The numbers copying down, yes. All right, well, this is Detour, EMDR.
Hold on.
For urge reduction, craving reduction, and we're just doing an internal resource today. The internal resource is when you recall a time when you feel resourceful, powerful, in control. You focus on the experiences and all the feelings involved with those experiences. If you freeze frame time and you're able to have a moment in time, you just freeze frame that period of time and recall that event. What event might that be? If you have all the different histories in your life, what would you think is the strongest where you felt resourceful, powerful, in control?
Being valedictorian.
Okay, good one. So I want you to focus on that.
Okay.
What does the image look like?
At the podium, dressed in cap and gown.
Okay. So just notice, follow me. And as you're noticing, you can increase the volume, change the contrast, make it brighter. You can tilt it if you'd like as a 3D image. Make it into focus more, sharper, brighter. Noticing all the sights and sounds and smells of the event. Also notice your body, how your body feels. How exciting that moment is for you. Very good. Just notice and remember. Just notice and remember. Very good. Okay, big breath in. I'd like you to think of one word to describe what you're feeling right now.
Accomplished.
Accomplished. Okay, I need you to put your hands on your knees. I'm going to touch your knuckle on one of your hands. And all I need you to do is think of the word accomplished and that memory, all right? And just follow me. Accomplished. Bring you back to that memory anytime you wish to recall it. Now I'm going to touch your knuckle. As I touch your knuckle, I'm anchoring that memory into your body. Anytime you touch your knuckle, think of the word accomplish. You'll be able to access this memory instantly. Bringing it back to where you were a moment ago and where you are now, thinking about that wonderful event and how your body feels. Remember how your body feels right now and the event. Okay, big breath in. So, that is the installation of that memory. So when you say the word accomplished, it should bring it to vivid recall for you. Does it do that for you?
Yes.
Okay. To be able to test what we just did, I'd like you to think of a sucky moment. Something doesn't have to be really bad, just a sucky moment that's not so pleasant. Just being in a memory that brings back something that's not, incredibly wonderful, like brings you into a more negative space.
Okay.
Are you there?
Yeah.
Okay. Now touch your knuckle or rub your knuckle and say the word.
Accomplished.
What happened?
I'm back to being accomplished.
So congratulations, you just now have control of your emotional states. That's what this process does. So that's now a new coping skill that you have. You can recall that moment anytime you need when there's something overwhelming or that you're having a bit of anxiety. And that's the process.
Can't I do this serendipitously where nobody knows I'm doing this?
Of course. It's your
I
knuckle.
don't have to necessarily be in this particular body frame.
No?
I can have my legs crossed.
You can do whatever you'd like.
Okay. So I can kind of like do it and nobody knows I did it.
That's right.
Okay.
That's what's so nice. And you can say the word to yourself without saying it to anyone else in your head.
Excellent.
So that's part one.
Okay. So I saw some questions popping up. Just kind of going back here. All right, I will yeah. So I'm going to answer these questions and see if there's any other questions that come up. But all in all, this is kind of, this is what detour is. And again, that's the one that I chose to learn about. I was able to access, actually, it was an on-demand training that AJ Popke had done. So it was kind of neat to kind of watch him do the training. He unfortunately passed away from COVID. Complications with COVID, so he's no longer with us. But he's on record. His legacy lives on with being able to see that. If you want to see EMDR craving reduction protocol, this is detour. That's a detour internal states resourcing. Part 2 is on YouTube. So if you so choose, you can go on part 2 and see what happens right after this. And it kind of goes into this gentleman's here for smoking cessation. So you're able to kind of see what comes of that. And just kind of looking, here are my resources. If we have an opportunity, I only have 7 minutes left. If we have an opportunity, I might go back to the slide. Well, actually, I'll just kind of go back. I'll go back to the slide with talking about the different types of protocols so we can go over that a little more, but I want to make sure that I answer any questions that are out there. So with that, I'm going to stop sharing screen if I can remember how.
Do you want me to redo the question, Shannon?
That would be great.
Yeah. Okay. So the first one, I'll even answer this one. Will the PowerPoint be available on the website? Yes, it will be. Probably by the end of the day today, So you can access this information and those video links. So question, on average, how many sessions does it take for someone to work through a traumatic event?
That is probably one of the hardest questions that is out there. So each individual is different, like any type of other therapy. Each individual has a different experience in it. So there's so many variables. If somebody has what's called a blocking belief. So sometimes when there's an experience that somebody experiences, they have like this attachment almost as part of an identity that they struggle then to be able to move forward from that. So to allow yourself to detach from that trauma being part of your distress in your life can be hard. So that can play a role. So sometimes we have to process a memory 2-3 times in session, 4 times in sessions to be able to get that. The goal is to get the SUDS anywhere from wherever it starts down to a 0. Sometimes I'm able to do it. Well, a lot of the time I'm able to do it to get it down to the 0 in one session, but it doesn't mean that the next session it's not going to go back up to a 3. So there's a lot of variables to that. It is designed to be a faster type of processing than other ways that you can, especially like traditional talk therapy. But to say, hey, it's like 12 and out, I can't necessarily say that because every person is different. I can say that I use the PCL5 as a pre and post. And so at the beginning, the highest you can get is an 80. I've had people that were in the 60s, and by the time it was done, they're in the 10s and no longer qualify for PTSD diagnosis, according to that screening form.
All right. Can you recommend a good EMDR training that is also cost effective?
That is a downfall for EMDR. EMDR is expensive. And so I have been very blessed to work for an employer that was able to allow me to have that opportunity to learn this and not pay out of pocket. There are some places, and if you go on EMDRIA's site, you'll be able to look at different locations. There are some places that have scholarships if you work for like a nonprofit. So the training usually runs about $1,500, but you can find it at like $900. You can find some of them where you just pay for the training itself, and then you can do the consultation over the course of the year each week and find a different consultant. So there are some options, but unfortunately, it's not a very cost-effective training to be able to get.
All right, next question. Is EMDR effective when done virtually?
You know what? You can do it virtually, and it's for any age bracket. So I think I forgot to say that at the beginning, and that's why children is included in this. Any age bracket. When I did my training, it was somebody who works with children, and they would put the tappers in the pockets of the kids, and they would do play, and they would talk, and the tappers would be going, and there's bilateral stimulation. So I do know that I have a coworker over at Blue Water that does only virtual and has had a lot of success. And the person I'm doing consultation with only does virtual and has had a lot of success with it.
Interesting. So next question. There are several similarities with EFT, tapping therapy. What makes EMDR superior?
EFT is tapping, but it's a different type of tapping. It's more of my knowledge of EFT, now mind you, I'm not an expert in it, but my knowledge of EFT is more utilized more as a coping skill or something to desensitize or lack the distress. What EMDR is to reprocess the memory itself so the distress and triggers don't happen.
All right, this next question might vary a little bit from practice to practice or person to person, but is EMDR a separate cost and or service from therapy, or is it always incorporated within it?
It can be, you bill out 90837. There are some insurance companies that because I find 90-minute sessions to be better because sometimes you can't get it done in an hour. if you can do a 99354, some insurance companies for prolonged therapy will accept that code. But it's kind of a hit or miss. I know Blue Cross does, but.
All right. How do you deal with disassociation?
Dissociation is, it can be a struggle. We do a lot of grounding prep work in that phase 2. Talk about grounding. Actually, AJ Popke, I loved it. In one of his trainings, talked about sitting on a yoga ball, because you can't completely disconnect from reality if you're on a yoga ball, otherwise you fall. So like there's some things that you can do, and also there's other protocols that I didn't address, like DNMS, that is specifically for people with dissociation.
And then our last question we have here in the chat is, have you ever done this with individuals who have schizophrenia or schizoaffective disorder, and what were the outcomes?
No, I have not. At Blue Water, we don't work with people with those diagnoses because we're not equipped. And here at CMH, I work with people with primary SUD. So if they had those diagnoses, they wouldn't be on my caseload. And I've learned this only a few years back. So that was the department I was in. So I have not.
All right. Well, thank you so much, Shannon. And just someone else asked in the chat which website I was referring to for the PowerPoint. It's the St. Clair County Community Mental Health website, which is sccmh.org. And it's the same place you went to register for these sessions. So if you return to that same page within our website, you can find this, or you will be able to once we get it posted today. And it looks like there's a link there. Go ahead, Shannon.
Can I answer this last question? Once you're trained,
Sure.
you keep your training, it's similar to CEUs, but it's EMDR based. So it has to be EMDR specific. EMDR has has all of the trainings on there, and that's kind of where, if you want to move on for certification, you don't need to though. If you're just trained, you can do that, and you can use this practice.
All right. So thank you so much, Shannon, for your time and all of this fantastic information today, and for all of you on our session for joining us. Just to recap, our presentation is one of many webinars scheduled throughout the month of September, and you can still register for any upcoming sessions at sccmh.org. Thanks again for joining us, and we look forward to seeing you all at the next webinar.